today. We have 4 presentations from multi-center projects done by the Saudi Critical Care Trials Group. We're so excited about these really high quality things. So we're going to hear the presentations, and I'm hoping that the speakers will give presentation maybe in 10 minutes or less, and give some time for feedback, which may help these projects also as a peer review form. So we'll start with the first project will be presented by Dr. Haifa Al-Guthami. She's associate professor King Abdulaziz University Hospital in Jeddah, who had done this multi-center study on Acinetobacter along with multiple colleagues from multiple centers, including Dr. Ayman Kharaba and others, and Acinetobacter infection. So the presentation today and predictors of survival from Acinetobacter infection among ICU patients. Dr. Haifa.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Thank you very much, Prof. Arabi, for arranging this, and thank you very much for inviting me to present this project on behalf of the Saudi Critical Care Trial Group and main author, Dr. Ayman Kharaba. So the Acinetobacter baumannii is considered as a threat in the world currently, with antibiotic-resistant Acinetobacter baumannii is a continuously emerging worldwide health crisis, with mortality rate approaching 50% in intensive care unit patients. The objective of this study was to statistically compare Acinetobacter infected ICU patients who died in the hospital against those who survived to ICU and hospital discharge, and to identify independent predictors associated with survival. So our working hypothesis was that at least some regional climatological, patient-related, hospital-related, organism-related, and prior treatment with antibiotic-related predictors would be revealed. The study was conducted, as mentioned, by Saudi Critical Care Trial Group as a combined prospective cohort observational study within 10 ICUs across 6 geographically and climatologically distinct cities across Saudi Arabia over 13-month period from June 2018 through June 2019. Hospital directors contacted through the over the kingdom. 10 hospitals agreed to participate and provided data to be included in our analysis, 3 in Riyadh, 2 each in Jeddah, Medina, and 1 each in Mecca, Tabuk, and Abha. Geographic, climatological, hospital-related, patient-related factors were prospectively collected on 3,179 patients, all patients with new onset clinically apparent Acinetobacter infection documented. Patient who find to be colonized with infection were excluded from our analysis. The overall incidence of Acinetobacter infection was 3.9%, and it ranged in our data from 1 to 7.9% across the 8 ICUs, with the highest in Jeddah and Riyadh and lowest in Tabuk and Abha. 169 patients with confirmed Acinetobacter infection enrolled in the study. Acinetobacter baumannii was confirmed in 167, that's account for 98.8%, with a single case of each Acinetobacter viti and intermediate Acinetobacter species. The primary outcome of the study was survival throughout the period of the patient follow-up, and the secondary predictors was independent predictors of climatological, geographical, patient-related, hospital-related, and organism-related predictors. So this table shows us the patient demographic, and we divided the age group below 30 and above 30. So we categorize according to the every 10 years to see if the age is related to the predictors of survival or mortality, male and female, nationality, admission to the hospital during the study period, during hot month, during winter and spring, and during summer and fall. Admission to the ICU, during the same period, and time of positive culture of Acinetobacter infection during the hot month or intermediate or cold month. Indication for admission, whether medical, surgical, and trauma were included in our study, and the source of admission from ER, hospital ward, or other hospital. This table shows us that we identify clinical risk factors for Acinetobacter infection in our sample. Prior hospitalization with 44%, hypertension, presence of hypertension, diabetes mellitus, or proper use of prior use of antibiotic in our sample, and instrumentation like prior central line, Folicath, TPN, prior mechanical ventilation, renal failure, being on dialysis, or use of nasogastric tube. So the out of 169 Acinetobacter patient, 86 discharged from the hospital alive, and 80 died, with one was still alive at the time of the analysis. This table comparing survival and non-survivors regarding demographic and hospital-related factor. So as you see here, the difference between survivor, which is 89 in our sample, and non-survival 80. The age was significantly as a predictor for survival in Acinetobacter infected patient. Male compared to female is high chance of survival, is almost like twice chance of survival compared to female. No difference in nationality. There was a difference between the cities and center, and that's like we plan in the future to find out what is the difference between a mortality rate according to the centers. But as you see here, the chance of survival is higher in Riyadh, Tabuk, and Abha, and survival is less in Jeddah. And when we did our analysis, part of this that younger patients were included in the study were in Abha and Tabuk, and older patient was very sick and more than one comorbid condition were in Jeddah and one center in Riyadh. We also consider the hospital factor, which is number of hospital bed, number of ICU bed, number of isolation room to ICU bed, and ratio of ICU hand washing station to the ICU bed, and there was no difference among survivor and non-survivors. The indication for admission, whether medical, surgical, or trauma, and as you see that patient admitted with trauma has a chance of survival better compared to the surgical and medical, and this is probably related to the older age plus prior antibiotic use and comorbid condition. Admission through ER versus transfer from ward or another hospital, you see chance of survival is less compared to the admission to ER and if patient transfer from other hospital. When patient is admitted during hottest month, which is anytime between May and October, compared to March, April, November, or coldest month during winter, there was no difference between survival and non-survival. If we compare monthly temperature at ICU admission, rainfall, and humidity, there were no difference, but there was difference in the mean altitude of the hospital in meters. So that's what's revealed that, as I mentioned, in Abha and Tabuk, because it's higher altitude, the mortality was less compared to the other regions. This table comparing survival and non-survival of the health status prior to positive culture. So as you see here, the chance of survival is less if patient had prior hospitalization, if known hypertensive or diabetic, and the prior use of antibiotic associated with better survival compared to non-survivor, but patient who is treated with carbapenem or aminoglycoside has a less chance of survival. Instrumentation like central line, Folicath, nasogastric tube, if patient on parenteral nutrition or mechanical ventilation, no difference among survivor and non-survivors, but there was a difference in mortality in patient with renal failure and on dialysis. Also that there is a difference between survival and non-survival, between high Apache score and SOFA score on ICU admission, and this was not unexpected, but there was a difference if the SOFA score increased between day 1 and day 3 between survivor and non-survivor. So increased SOFA score between day 1 and 3 associated with higher mortality in our sample. Regarding the source of infection with the respiratory tract, blood, skin, or other fluid like urine, pleural fluid, or other fluids, no difference in survival and non-survival regarding outcome. There was no difference in antibiotic resistant between survivor and non-survivor, but when resistant to meropenem or colistin, the chance of mortality is higher if the patient has high resistance to meropenem and colistin. So of 169 patients with confirmed Acinetobacter infection enrolled in the study, 47.6 died in our sample. And this is not far from or consistent with the international data reported that mortality was 42.6 in meta-analysis which published recently of 27 data published about Acinetobacter related mortality. Survivors were statistically younger, predominantly male, more likely to be admitted for trauma, less likely to have hypertension, diabetes, or renal failure, or to have undergone hemodialysis, and more likely to have been treated with antibiotic prior to having a positive culture for Acinetobacter, but less likely to have received an aminoglycoside. Also, survivor had the lower baseline Apache 2 and SOFA score and were infected with the strains of Acinetobacter that had less meropenem or colistin resistant. Our binary logistic regression analysis identified 5 predictors of mortality in our sample that ICU day change between SOFA score between ICU day 1 and 3, that higher score associated with increased mortality, patient on receive hemodialysis associated with 4-fold increase on mortality, higher score of Apache 2 associated with increased mortality, and medical indication for admission to the ICU, higher mortality risk compared to surgical and with the least of trauma patients. Age is another predictor of mortality in our sample. So according to the age group, as you see now, if the mortality increase with the increased age group, with the lowest in the younger age group, and highest if patient more than 50 years, with the highest mortality account for 64% if more than 70. So multivariate analysis identified the following independent predictors of survival: that younger age, lower ICU day 1 Apache 2 score, and a lower ICU day 3 SOFA score, being admitted for trauma, and having no history of hemodialysis. None of the regional hospital-related factors were independent predictors for survival. So the conclusion of our analysis that patient-related factors outweighed regional and hospital-related factors as a predictors of survival among critically ill patients with Acinetobacter infection. Thank you very much. I end my presentation. I'm happy to have questions.
Thank you very much, Dr. Raifa, for this great progress on this important study. Really very insightful and gives a lot of information about this serious problem. So for the attendants who have questions, maybe please raise your hand so we can unmute, and if we can have a few comments or questions. I think the nice thing about the study is that you included patient level factors, hospital level factors, and also city level factors to account for different measures of outcomes. So this is really interesting. Did you come across other studies that have similar outcomes from other regions? And then we'll have a question from Dr. Yasser. If you can please, Rose, if you can unmute. I see raised hand.
To our knowledge, this is the first data in Saudi Arabia about incidence and mortality regarding Acinetobacter infection in Saudi Arabia.
Yeah. Very good. Any questions from the audience? Dr. Yasser, I see raised hand, but I'm not able to unmute. Dr. Yasser, can try to unmute yourself?
Yes, now because it wasn't allowing me to unmute before. Yes. So my name is Yasser Tolba. I work in King Faisal. Thank you very much for this nice presentation. Just a quick question about the previous antibiotic use. So I mean, is any about this is like a current problem, like we are actually overusing antibiotics, and we're starting always with broad spectrum antibiotics in our in our practice, ICU practice, not only restricted to one hospital, it's all over the country. And I think we need to take this study forward as an evidence that we need to modify our antibiotic use and de-escalate early. I think is a national issue, and to get the early results of cultures, to have
Dr. Yasser, we lost the connection.
Sorry, can you hear me?
So Dr. Haifa, you got the question or the comment?
Yeah, yes.
So maybe you can comment on this, on the antibiotic use.
Well, antibiotic use in general is not associated with increased mortality in this sample, but when the antibiotic prior use of carbapenem like meropenem or colistin, mortality was significantly affected. So I think just because if a patient, if you use this antibiotic or abuse those type of antibiotic prior, when we come to the Acinetobacter infection, then are resistant already there, and the response will be bad, and an outcome will be affected with increased mortality. So since now we have emerging resistant to among the most, like actually 17 antibiotics were studied during the when we analyzed the antibiotic like the ceftriaxone, Septrin, so 17 antibiotics. Among them, the only that is associated with increased mortality is the resistant to meropenem and colistin, and I think this because of prior or abuse of those two agents in our centers.
Very good. Thank you, Dr. Haifa, for this great project. I think we're gonna hopefully we'll see it published very soon, and it will have a great addition to the existing literature on this topic.
So thank you very much, Prof. Arabi. Thank you all for listening.
Dr. Alia,
yes, I am. I'm around, Dr. Yasin.
Can you share your slide?
Yes, I will.
So next presentation is by Dr. Ali Al-Hazmi. Dr. Ali has led the multi-center database registry for COVID-19, the largest in the country. Really great work on this. And she's going to present to us her finding on prevalence and clinical outcome of COVID-19 associated ARDS. So very exciting topic. Dr. Ali, تفضل. Are you able to share the slide?
Can you see them? Yes,
yeah.
Yes. Thank you very much for the invite, Dr. Yasin, and for your supervision and kind guidance through the whole project. I'm going to talk about the outcome and prevalence of ARDS associated with COVID-19, and using the database or registry that we did from centers all over the country. with the contributions from the biggest centers, and I would like to thank all the contributing authors and data collectors who made this happen. You could see a list of the hospitals where from Riyadh, the West, and the East, they contributed into the study, and more than 20 authors from these centers were included. This project is fortunate enough to have Dr. Yassin's guidance with us, and we're still maybe in much early stages in this project than Dr. Haifa's project. So our purpose in this research is to study the rate of ARDS and classify ARDS-related COVID-19 disease in our hospitals at the time of ICU admissions. As described, this is cohort retrospective. It's a cohort pro and retrospective multi-center study that were conducted in critically ill patients. And the patients who fulfilled the criteria were ARDS. We were able to classify ARDS on admission to ICU were 1,154 patients. So they were classified into mild ARDS, moderate ARDS, and severe ARDS based on the Berlin definition of PF ratio at the time of ICU admission. I'm going to share with you the preliminary results, and would appreciate any feedback or suggestions of or comments on what do you think we could add or edit with our data. So this is the general characteristics, where you see that maybe the presence of chronic lung disease and coexistent asthma was one of the important variables that differs among the classification of severe ARDS versus moderate versus mild on the time of ICU admission. SOFA score, to be honest, when we look at our data, we thought that SOFA score is not representative of the severity of COVID-19 disease, and mainly the respiratory factor of or respiratory criteria of the SOFA was actually the more predictive one. So we looked also at the interventions were applied during the ICU stay. We noticed that the more severe the ARDS on presentation, the more likely the patient would receive invasive mechanical ventilation. ECMO requirement, I'm not sure if this data is well representing the use of ECMO, because few of the patients who received ECMO came to the recruiting centers as retrieval. So on arrival to ICU, they were already on ECMO. So this is one of the limitations of the analysis of the ECMO outcome. The requirement of high flow nasal cannula, we were impressed with the number of patients who received high flow nasal cannula. Almost almost a third of the population received high flow nasal cannula. We noticed that also higher number of severe ARDS required non-invasive application, and the rescue therapy with the intubation and mechanical ventilation start was also collected. The more severe the ARDS, the more likely the patients would receive corticosteroids. We are looking again to the other immune modulators that the patients receive, and so forth. We looked into the complication during the ICU stay, classified according to the severity of ARDS. We reported positive respiratory culture, as we didn't diagnose them as ventilator or non-ventilator associated pneumonia. candidemia, and other complications like thromboembolic disease, and the presence of pneumothorax and barotrauma. In addition to the outcome, we measure the duration of mechanical ventilation, which we will convert into mechanical ventilation 3 days, length of stay in the ICU, and the survival in the patients classified according to their severity of respiratory failure. And maybe the Kaplan-Meier curve would show better the survival according to the severity of respiratory failure. And these are by the days since ICU admission. We started with the multi-logistic regression analysis to predict the predict the outcome according to our data. And we will definitely show more and shed more light about the regression analysis and the graphs. But we noticed that the poor predictors of the invasive mechanical ventilation still has a high odds ratio, and the use of rescue therapy like high flow nasal cannula. And what else? And we noticed that the we failed to see any relationship or effect of body mass index on the outcome on the multiple logistic regression analysis, despite we expected to have different outcome. So we're still in early stage, and we would like to get your feedback or any comments. They will be very welcome.
Thank you very much, Dr. Ali. This is a great project, and I think it's is adding more information. I think there are a few points that we like to understand more. I think one of the issues is the prevalence versus incidence here. So when you classify mild, moderate, and ARDS, this is based on admission criteria, صح? So this is prevalence.
Yes, admission to ICU at the day of ICU admission.
صح. I think one of the challenges of understanding this is that you could have somebody intubated on day 1, and because of the PEEP and being ventilated and sedated, he may fall in the mild ARDS, but he's actually severe. Is that possible? And if you take somebody who is on, who got intubated, moved to the ICU intubated on PEEP of 10, FI2 40%, he may very well fall within the mild ARDS or moderate, not in the severe. And I think this may explain the next slide. Can you show the next slide? لأن في أشياء شوي next slide لو سمحتي. This one. So if you look,
the one before, yeah.
The one before.
Sorry.
And if you look at the difference in invasive mechanical ventilation between the 3 groups,
not very
almost nothing, no difference, right? Okay. Almost no difference. أتوقع you need to add another variable, which is new invasive ventilation. Yeah, for patients who are not intubated on admission.
Okay. Yes. Okay.
Are you following me on this point?
Yes, I understand. It's just like the incidence of CRRT in ICU, and then you find that a quarter is already receiving hemodialysis at home. So it is not a new. It's not a new thing.
Yeah, because it will bias you against the difference. Yani intubated patients, because they are intubated, sedated, paralyzed.
Yeah.
The oxygenation will improve, so they will move actually from severe to mild category. With severe, you'll have more the high flow on high FiO2 because they're just high FiO2. So, and that probably will limit seeing meaningful difference. So to overcome this, one option is to look at progression of the disease. So maybe look at new invasive mechanical ventilation for patients who are not intubated initially. Well, I think we need in the first slide, if you go back.
Yeah.
We need in the first slide to know the respiratory support at baseline.
Okay.
And we need to know when you consider mild ARDS, is that during intubation or in an intubated patient or in high flow or BiPAP. أتوقع that will give a better picture. النقطة الثانية which a little bit I'm trying to understand better here, if you go to the predictors.
Okay.
Predictors يعني ما أعرف أنا so this predictors of what?
These are predictors of survival.
These are predictors of survival among the cohort.
Yes.
Yeah, but there are a few things that don't really match. Like
احنا
age.
initially عملناها for mortality. But then the graphs we did يعني to unify the what do we call it? To unify the outcome, either survival or mortality. Looking into this, it looks like for mortality.
Anyway, I think we need to look at this model a little more cautiously because age looks like a higher age is associated with better outcome, which doesn't make much sense. We need to include the respiratory support at baseline.
Okay.
And then maybe the progression as a separate variable, progression to invasive ventilation. Because I think it's skewing the model. The ages looks like protective. Older people do better. This doesn't, we know this doesn't make much, this can't be.
Yeah. In our country, they die.
Well, not everywhere. I think age is increasing age is associated with increased risk of death. This is actually in all COVID studies. There is no controversy about it. So it cannot be older people do better. So it's probably related to some collinearity, something related in the model that is skewing the finding. I don't know if there's comments from the team.
دكتور ياسين السلام عليكم.
تفضل. عليكم السلام ورحمة الله وبركاته.
خالد مغربي.
حياك الله.
Thank you very much. What I would like يعني to stress an important point for the mortality. I think it will be very good to look at ICU mortality and hospital mortality for both of them. We are seeing patients now, they're staying longer in the hospital, and I think it would be more representative to look at hospital mortality too. The other thing for among the factor they may affect survival is the coagulopathy reflected by either development of venous thrombus embolism or indicator of thrombosis like level of D dimer, level of inflammatory indicators or markers. If it will be included, that would be good. Another point with the duration of support before intubation, either duration of high flow or non-invasive. If this will make a difference and reflect how the patient will behave later on mechanical ventilation, maybe something that you may consider in your analysis. Thank you very much.
Great point. Thank you very much. It's a really good point. I think we'd like to see also a Kaplan-Meier curve of progression to intubation. So intubation in patients who are not intubated initially. Next, Dr. Hani, Dr. Hani Timsah, if you can unmute.
Assalamu alaikum. Yeah, thank you very much. Thank you, Dr. Alia and Prof. Yassin. Wonderful study with a high number, which is really needed at this time. Really excellent work, mashallah. Surprisingly, the BMI, you said there is no correlation with the outcome. This is a little bit surprising for me. We know that, okay, some factors may be different from one population to another, but similar to the age issue that Prof. Yassin mentioned, maybe we need to double check this issue. Did you have any data about the phenotypes of those ARDS? As you remember, Prof. Yassin, maybe a year ago, there was the Italian group that reported different types of ARDS with COVID and the outcomes of them. I wonder, can we extrapolate from the current data, or it's not about the outcomes of these? Because that's a question we were discussing with other colleagues the other day. So I'm not sure if that can be extrapolated from this data. However, I do support.
Yes, Dr. Hani, maybe, I mean, I think Dr. Ali has some. I think you have the data on compliance.
Right? I do for intubated ones, yes, and especially in the first 5 days, and we are reporting it in the main study. That we will publish that one, and we can take a look at them as a subgroup analysis. I think one of the challenges in our study is that these, to start with, they are not all receiving the same respiratory support.
Exactly.
So it will be difficult. So that means, I'm just thinking about it, Professor, if I divide mild ARDS, moderate, severe, and then I put a different division here of low flow oxygen, high flow oxygen, intubation, this will be what, 3 in 3, 9 groups to compare.
Yeah, I agree with you. I think what you've done is mild, moderate, severe is by Berlin definition. I think it's okay, but you add them as variables in baseline characteristics. So,
definitely, yes.
Yeah, and then
as a subgroup analysis, we look into those who were intubated and we look back.
Either this or we adjust for the level of respiratory support. The multivariate model. Sure.
Yes, this sounds very good.
Wonderful. And go ahead, and I do hope you publish it in the nearest future, because it's really needed. Even if you make it as a preprint, this is wonderful work. Congratulations, dear colleagues.
Thank you so much.
Shukran.
Thank you, Professor.
We have comments from Dr. Iman Ahmed and then Dr. Yasser. Iman?
Yes, Assalamu alaikum, Prof. Yassin. Assalamu alaikum, Dr. Alia. Thank you for this presentation. My question is just regarding the how did you categorize this invasive and non-invasive? Based on oxygen saturation index, or you use the oxygen index, saturation index, or this oxygen PS ratio for non-invasive? Because as Prof. Yassin said, maybe the patient in non-invasive more severe case as a patient on invasive. It depends how we manage them sometimes. So are we measuring these values for both of them, and we categorize accordingly?
Yes, I looked into multiple studies who are reporting similar idea, either in COVID or non-COVID. Everybody is dividing ARDS based on VO2 to FiO2 ratio, regardless of the oxygen support. And I think that brings us into the importance of this. And I will try my best to see how can we describe them in subgroup analysis, or even looking into one group versus the other. We'll look at them first as a big group, and then we will see how we can look at them, because I agree with you. And Dr. Yassin, he explained this before. So we will try to see how we overcome this limitation with the best way statistically. With the large, if they were 40 or 50 patients, it will be easy to look into everyone. But with 1,000 patients, it will be difficult, and we need to find a unified, clear way to categorize them.
Okay.
Sounds good. Dr. Yasser, last comment, really great comments from interacting on this paper. So Dr. Yasser.
Yes, thank you very much for the good presentation. Just a quick, 3 quick points about the time scale of the study, because we know that the guidelines has been changing. For example, the non-invasive was not recommended early, and we have been intubating people early, and then it started to come in. So I think this might be a confounding factor as well about the time scale. Also about the steroid use, steroids was not like a mainstay except after the Oxford and recovery study has been coming in. So I think the time scale can be, you know, a factor. We need to consider that. Number two is about that the ECMO requirement. You said about 5.5% or something in
Yes.
especially in the model. And did this patient go ahead and take the ECMO? Just this is just these are the patients just defined to have ECMO but did not have them. Thank you very much.
So in regards, you will be surprised that more than 80% of our population received good doses of steroids. The timeline where until November 2021, and more than 80% received the steroids. So and a good number received 426 out of 1,500 or 1,470 received tocilizumab. So I think even the guidelines of steroids came in late, but people saw the difference and they started treating with it early. In regards to the ECMO equipment.
Yeah, Dr. Ali, steroids, what I see on the slide on the screen, if I understand this correctly, mild ARDS, 11% received steroids, moderate 34 and 54. Are we sure about these numbers? They look low.
We can definitely double check.
I expect it will be much. I thought it's much higher.
So 900 out of 1,000. This adds up to 850 to 900 out of 1,100. I will double check them definitely.
Yeah, because if that's the case, if what's written on the slide is correct, that's another confounding. So mild ARDS, if they only 11% receive steroids, that will, may explain that why the mortality wasn't much different between the three groups. Maybe, but let's double check this one.
Sure.
Excellent discussion. So thank you very much. Looking forward to get this project in full publication. So good luck with it, Dr. Alia.
I would like to thank all of the group who worked really hard, really in all the phases. And Prof. Yassin, thank you so much for your guidance. I really appreciate it. And hopefully we will, maybe if we meet again, or we'll see how the analysis progress.
Inshallah, bismillah.
Thank
you. Next presentation by Dr. Hassan Durzi. He'll present the other multi-center project on, it's called SOAR ICU, which the prevalence and risk factors and management and outcomes of pressure injury in patient admitted to ICU. Very important topic. Very often we don't pay enough attention to it. So thank you, Dr. Hassan, for bringing this issue up. Can you share your slide?
Doctor, who's the next presenter, please? Sorry.
Dr. Hassan Durzi.
Okay.
Hassan, can you unmute yourself?
I'm not able to share the screen. Can you allow me? 1 second. Do you hear me?
Yes, I hear you.
But I'm not allowed to share the screen.
I made you the co-host, doctor, already.
Try now, Hassan.
Not able.
Not able.
Just wait, doctor. Just wait. Okay.
Yes, now.
Okay, thank you.
Do you see my slide well?
Yes.
Bismillah ar-Rahman ar-Rahim. So I'm going to present today some update about this project, which started in 2018. So it's called SOAR ICU, and it is a prospective multi-center study looking at the prevalence, risk factors, management, and outcomes of pressure injury in the ICU. So the primary objective of this study is to establish in a mixed population of ICU patients in Saudi Arabia the prevalence of pressure injuries, pressure injury risk factors, pressure injury management, and pressure injury associated outcomes. So it was, or it is, a point prevalence study with follow-up for up to 28 days. So we selected certain date, and on that date, we looked at all patients in the ICU and we evaluated them for the presence of pressure injury, and we followed them up for up to 28 days. So this study was performed at multiple centers in Saudi Arabia, and the assessment was done by a trained physician and a nurse, as I said, on a pre-selected date. We used the National Pressure Ulcer Advisory Panel staging to stage the pressure injury. We collected concise and focused data. These data were at hospital level and ICU level. So we have hospital and ICU level data looking at the characteristics of the hospital and the ICUs and what is being done for prevention of pressure injury and also for management of pressure injury in general in these ICUs and in the hospital in general. We also collected data at patient level, and the data were focused, but actually the data were rich. So we had lots of data collected on the patients. We evaluated the presence of pressure injuries. We looked at up to 4 pressure injuries. We looked at their location, the stage of the pressure injury, whether the pressure injury was acquired at home, in the hospital before ICU stay, during ICU stay, whether it was device related or not. And also we looked at the management of pressure injury. So now I'm going to present preliminary results. The data entry is not complete. However, I took this presentation as an opportunity to look at the quality of the data and to try to see what should be done in the future to optimize and verify the data. So we had 7 hospitals who participated in this SOAR ICU study. 2 hospitals from Riyadh, 1 hospital from Jeddah, actually 2 hospitals from Medina, 1 hospital from Dammam, and 1 hospital from Abha. All the hospitals reported using the Braden scale for pressure injury risk assessment. 50% of them reported that physicians get routine education about pressure injury and the management of pressure injury. 100% reported that nurses get routine education about pressure injury and its management. All the hospitals reported that they have wound care teams to handle patients with pressure injuries. All reported having pressure injury management protocol. And there was variability in the use of specialized ICU matrices. I did not report all the findings. Some of the findings need more verification and more cleaning. So I'm reporting part of the results. So far, we have data entered on almost 200 patients. So the mean age of the patients in this study was 54 years. Most of the patients were males, more than 70%. Body mass index on the average was 26, and the mean Apache score was 28. So the patients were very sick in the ICU. The prevalence of the pressure injury on the study date was 39.7%. So 40% of the patients had at least one pressure injury. Some patients had multiple pressure injuries in multiple sites. So overall, we had 133 pressure injuries. So for the patients who had pressure injuries, it was almost 2 pressure injuries per patient. Now, when we looked at the location of the pressure injury, the most common site of pressure injury was the sacrum, followed by the trochanter, and then the heel. Many patients had various signs. Unusual sites of pressure injury, like in the neck and the chin and the nose. Eventually, we have to classify them, but overall, the most prevalent site is the sacrum for pressure injury in our study. Now, regarding the stage of the pressure injury, and this is looking at the 133 pressure injuries we had. Stage 1 occurred in 11% of patients, stage 2 in 44%, stage 3, 11%, stage 4, 7%, and we had a significant number of patients who had unstageable pressure injuries or suspected deep tissue injury. So almost 1/4 of patients had these classifications of pressure injuries. Where the pressure injury was acquired, so according to the study, around 30% of the pressure injuries were thought to be acquired in the ICU. Another third occurred at home before ICU admission, and another third occurred in the hospital before admission to the ICU. How often did we see device-related pressure injuries? We saw it in 10% of the pressure injuries. So 10% of the pressure injuries were device-related. So we classified, or we categorized patients into 2 groups. The first group are the patients who had no pressure injury or stage 1 pressure injury, which is very mild and usually reversible. And the second group are patients who had stage 2 or more or higher pressure injury. And we looked at the characteristics of the 2 groups of patients. We found that the patients who had stage 2 or more pressure injuries, they were older, and the p-value was significant. So 62 years compared to almost 50 years in the patients who, for the patients who had stage 1, stage 0 or stage 1. No difference in gender. Surprisingly, no difference in body mass index. There was a significant difference in the functional status before hospital admission. We looked at the Rankin or modified Rankin scale for functional status, and with the worsening disability, there were more pressure injuries and more higher stage of pressure injuries. More pressure injuries occurred more in medical patients compared to trauma patients. Sepsis was more common in patients with stage 2 pressure injuries or more. There was no difference in Apache score. This is a bit surprising, but there was no difference in Apache score. There was no difference in mechanical ventilation. Patients with the stage 2 or more pressure injuries had more shock state and vasopressor requirement compared to the first group. Albumin level was lower in the stage 2 or more group, as well as pre-albumin. So this is part of the characteristics of the patient. I have much more data than this, but I selected these important information to show you in this presentation today. I did a multivariable logistic regression analysis. I put in it multiple variables. I did not put it here. However, I found that there were two independent predictors of the pressure injuries. The first one was the age. So as the age increases, the risk of having pressure injuries stage 2 or more increases. And you see the odds ratio, it was 1.07. And also the pre-hospital functional status. So as the functional status becomes worse, so more disability, the chance of having pressure injuries was higher, which is expected. And these are the two variables that had p-value of less than 0.05. The other variables did not have did not reach statistical significance. Now, as I said, we looked at outcomes by day 28, where after the study day, and we found that there was an extra 5%, almost 5% of patients who developed new pressure injuries in the subsequent 28 days. So this is shown in this graph. We looked at other outcomes. I showed you the ICU mortality outcome and the hospital mortality outcome. And obviously, the ICU mortality was higher in the patient who had stage 2 or more pressure injuries. However, for hospital mortality, there was no significant difference. As I said, these data are preliminary data. I received the data actually only yesterday, and I did the analysis this afternoon. And the reason is that data entry is not complete. So we have to complete data entry. We have to do data cleaning and verification. Obviously, I found especially in the hospital level data, there are still missing information, or the data were entered in the wrong way. So I have to follow up with other investigators to correct these things. And then after that, inshallah, we will do the final data analysis, and we will work on the manuscript, and hopefully it will be published. I would like to thank all the investigators in this project. Many people were involved in this project, and many of them their names are not showing in this slide. So I would like to thank all of them, and also I would like to thank all the nursing staff who helped in this project, including the nursing staff at our center. And this is my last slide. Thank you very much. If you have any questions, I'm happy to answer.
Thank you, Dr. Hassan. This is a great presentation, very well done. Really important data there that deserves our careful attention. I'm really you know, one striking thing is the very high prevalence of pressure injury, almost 30%, almost 1/3 of the patients, right, or 40% of patients. It's very high. I did not expect it to be this high, 40% at any given time. Just to remind us of the inclusion criteria, is it all patient on that day or?
Practically all patients on that day.
All patients in the ICU, but
yes.
Yeah. Is there a reason why it sounds too high, 40%? And if you walk in an ICU on a given day, do you expect to see 40% pressure? Any explanation for this high number?
I don't have. This is what we found, and this has been seen in other studies. Maybe in this study it's higher than other studies, but the numbers are high. This is what it's showing.
Right. Yeah. And so many of them, 1/3 acquired at home.
1/3 acquired at home, 1/3 acquired in the hospital before ICU, and 1/3 in the ICU.
In the ICU before the observation day. Okay, very good. Any questions?
And 5% had additional pressure injuries by day 28.
Yeah, so that's the incidence. It's 5% in 28 days. Okay, questions. We have Dr. Iman and then Dr. Khalid Maghribi. Dr. Iman.
Hello, yes, thank you for allowing me. I mean, my question is the inclusion criteria. You have included many patients who already affected with SORS. So, I mean, your study, you are trying to study the efficacy of ICU in managing cases properly, so not to have bed sores. Is this not affecting your data?
Can you repeat the question?
I mean, you have patients included already with bed sores. They are coming from home or from hospitals. Before ICU, they have sores.
Yes.
And then they develop more sores. Yes, so, I mean, how can we say this is from the ICU? I mean, the care of the ICU. I mean, we have problem with the ICU care, nursing care, or is it?
I'm not saying this. I'm saying that on that day of the study, these patients, this is the number or the percentage of patients who had pressure injuries. And I'm not. I'm saying that 1/3 of the pressure injuries in the that were seen on that date were acquired in the ICU, which is not a small number, but not the majority of patients. And we have data about what management was done, and I did not look into the management of pressure injuries, but one of the purposes of the study is to look into the management and see if we are doing the evidence-based management or not.
So I think related to this question, so this question is, I think what Dr. Hassan is addressing in the study is the prevalence on ICU admission. So it took all patients, but might be also reasonable to look at the incidence in 28 days in patients who did not have bed sore. So new,
yes.
So the ones who are bed sore free.
Yes.
Okay.
And so the patient who already had bed sore is high risk to have another bed sore, you know.
Yes.
Yeah.
Yes.
So maybe take the ones who are, so the analysis is great what you are doing, but maybe one additional piece can be added, which will be
for sure. Yeah.
Informative.
Great.
To look at the one who are free from bed sore and how many of them have bed sores. I think that might be useful. Dr. Khalid and then Dr. Hani.
Thank you, Dr. Hassan. Dr. Hassan, for the design for point prevalence, would you think that extending this study a little bit further will be helpful to find, for example, what are the contributing precipitating factor, things that we have to work on it, or you think just a point prevalence can give us enough information of the condition?
But this is why we did it. We did follow up for up to 28 days. I did not get the question. Can you repeat, please?
I think Dr. Khalid is asking whether different design like cohort will add more information, but what you
Well,
point
the issue of the design, we tried to do a study that is feasible. Whenever we do a study, we look at the feasibility, and this is outside the results of the study. Even for this, so we thought that this design is relatively simpler than doing a prospective cohort study, which will need much more resources to do. And this is maybe the start of looking at this topic in general.
Yeah.
So even with this design, we struggled to have centers joining us, but I think this type of design is good for such type of questions.
Dr. Hani.
Yeah, Assalamu alaikum. Thank you, Dr. Dorsey. Wonderful efforts. And you just received the data and very quick analysis, mashallah. May I ask, so now you said the 28 days prevalence of new bed sores. What about looking, also reporting the 28 days resolution, or what happened to those point prevalence bed sores, the one that were checked initially?
We have
and
data
what's the
about,
factors?
We have a data about that, but I did not present these data.
Beautiful. So looking at the positive and the negative aspects together, that's wonderful.
On follow-up, we looked at what happened to the pressure injuries that were present on the study date. Did they progress or they regressed? So we have data about this, but I did not do the analysis on on this thing.
Yep.
So thank you, Hassan. I think this is a really great study, very informative and insightful data, and I think it will help us moving forward on this important topic, clinical practice. Excellent. So looking forward to get this full publication. Thank you, Hassan.
Thank you.
Next presentation is another exciting project by Dr. Rabi Ahmed, who's done a remarkable job actually putting together one of the largest registries on ECMO, and he's going to present on the Middle East experience in ECMO for COVID-19, the results. I think this, we're really looking forward to hear about this because this is a question that we face every day. So Dr. Rabi.
Doctor, who's the next presenter, please?
Dr. Ahmed Rabi.
Ahmed Rabi. Can he raise his hand so I can see?
Can you raise your hand? Don't see. Yeah, no, I see his hand raised.
Okay.
You should be able to unmute now.
Okay, doctor.
Can you share your slide?
You hear me, too?
I hear you, yes.
Thank you, Dr. Asim, for this opportunity to present our work, and also thank you for monitoring with Alincom this project. I will share my slide.
Yes, please.
Is it clear now?
Yes, it is. Go ahead.
Yes.
Can you make it full screen because we see the desktop also?
I'm trying.
Share the document, not the screen. Share the.
Yes, I'm trying to adjust it. 1 minute. That's fine?
It's good, okay. Yes.
That's fine. Okay, again, today we're going to present our work. This work get for more than 1 year experience until we get succeeded to publish the paper in Intensive Care Medicine Journal. The Middle East engine experience and results during COVID-19 pandemic. I have no disclosure and even no fund for this work. The study title called Implementation of New ECMO Center during COVID-19 pandemic experience and results from the Middle East and India. And this is a great team involved in the work. It includes the Saudi team, 5 to 6 ECMO expert like Dr. Azzam, Ali Al-Harsi, Hani Mufti, also Dr. Abdurrahman Al-Harsi, Dr. Yassin Orabi. Then from the SWAC ELSO group, all the experts involved. Outside SWAC ELSO group, also international expert involved, including Alan and Daniel Comb and Daniel Proudy and Karan Shikar, and they will ask to thank all of them for this great help. We did a strong work to collect 307 patient COVID-19 received ECMO, and we analyzed the data. The background of this paper that during the preparedness of COVID-19, due to lack of the ECMO service in a geographical distributed area in the region, some countries started, including Saudi Arabia, starting to initiate or starting a new ECMO program supervised by ECMO expert and central management to cover the service in area like in the periphery or area where restricting transportation. At that time, unfortunately, ELSO guidelines recommend against new guidelines. So in compliance with this, we kept we did not follow starting any new ECMO center, and we observing the already initiated one, and we focus on the established center. Then the new center debate started to rise. We started to do a position paper concluding more than 33 ECMO experts worldwide. However, it was not published. Also, we did an editorial and including the model of ECMO provision in our area and how far it is leak ECMO service. Then we did a serial interview and meeting with ELSO steering committee, trying to convince about the situation in our region. Then eventually we collected some baseline data presented at, they start to be convinced. Then this basic data grow up to a more granular data until we get full data. At that time, the updated ELSO guidelines 2021 became more stringent against a new ECMO center, and they mentioned in selected case, which is our finding. Lastly, the paper, as I told you, accepted in the European Intensive Care Medicine. It's in the production state, and we're waiting for publication. Our study is unique, and it's to consider the second biggest cohort in a group of patients received ECMO for COVID-19, 307 patients. The first is ELSO registry published in the Lancet 2020, then our cohort, then the recently published from Paris, Leperton et al. Published 302 patients. It's comparable to our result as we will see. Then there is American also, Mustafa et al. He has 149 case, then the Schmidt 82. So we consider the second biggest cohort, as I told, and the first and only paper evaluated new center outcome and results. Our studies guided the guidelines. The study design was retrospective multi-center international observational study. We're collecting data from 19 centers in 5 countries from March 22 to December 22. This 19 center, including 9 center from Saudi Arabia, and the setting, we precisely describe the operational management of the new center, how we design it, how we supervise this, and how we provide support and retrieval by the GREET project from the MOH directed by Dr. Azam. And also we're providing the training provided also by the team in the ECLS chapter all over the country. Also outside the Saudi Arabia, there was a lot of initiatives of training and supervision in India, in Kolkata, Dr. Arman Chakraborty, and in Kuwait, Dr. Abdul Rahman. So our inclusion criteria, we included all consecutive COVID-19 patients admitted and treated in the participating center with VV ECMO and VA ECMO for acute respiratory or circulatory failure. The outcome, the primary outcome was survival to home discharge. Secondary outcome including survival during ECMO support and survival to ECMO decannulation. The demographic data and the patient characteristic. The patient, we found that the patient median age was 45, 81 mean, and 94 received VV ECMO. The MORE score was median 3.5, and the SOFA score was 12. During the analysis of the new center, patients treated in new center were younger, less frequently male, had received a higher PEEP, more frequently in tropes and more prone position before ECMO, and were less frequently retrieved from referral center on ECMO. These all finding lead to the final outcome that we will see later on. Going again for the characteristics, 58 of patients had received vasopressor. From the all cohort, 52 had received the prone position. Prior ECMO initiation, the median number of days was 2.5. The BF ratio was 60, the lowest BF ratio among the article published and all experience published in COVID. The median PEEP and the driving pressure before ECMO and on ECMO day 1 were 13 and 8, then 20 and 19 for the driving pressure. Then the outcome, we reported 45%, 138 patients out of 307 patients discharged home alive. And again, it's not discharged hospital, it's discharged home alive. And because this will be compared with the other results in the literature. While 58 patients survived ECMO, that means that 178 patients decannulated from ECMO, then died later in the ICU. The median duration of ECMO support was 15. For the new ECMO outcome, for new center outcome, here we present the Kaplan-Meier, and we see that the new center outcome is significantly than the established center, and this was during the univariate logistic regression analysis. However, this difference was no longer significant when adjusting all confounding using the multi logistic regression. LP value was 0.2 here in univariate logistic analysis. Regression was 0.36. So the discussion, we opened the discussion to comparing our results with the results in the literature, and we have first the ELSO registry, where Paparo et al. He reported 37.4 estimated mortality at day 90. Then When we compare this with our results, we have a final disposition, but this result was earlier during the pandemic, and it was including all patients outside discharged outside of the hospital. It was not all home discharge. Some patient discharged to other center or long-term or rehab center. Then the same was Paris Laboratory experience. They have a unique, very, very nice result. They reported 30% mortality an estimated day 60, and this result was comparable to what's in non-COVID patient presented in the YOLIA trial. However, we mentioned in our discussions that the unique experience from Paris Liberty should not be globally or generalized, because this center is very expert center. They manage more than 500 ECMO patients per year. Then we go to the URLSO survey, where they estimate 41% estimated also mortality. So all this previous paper was estimated mortality cannot be compared to our result. The Paris experience, including the LBT experience, recently Rebriton et al. They reported 302 patients, and the outcome was 46% home discharge. It's very comparable to our results. Our results 45. Then the coming also guidelines was Badaluk et al. They changed the, they told you the guidelines and make it less stringent to provide new center in selected cases where there is a lack of the service in geographical distribution, or there is any limitation of transportation or retrieval. And for sure, we go through this also guidelines in the discussion, and we mentioned how we were compliant with the ELSO guideline from the first. Then we started to work on ourselves and the supervision for these new centers and the training provided to this center. Eventually, we succeeded to do that. However, there is a lot of limitation also in this study. One of them was the ventilatory management. In post-ECMO, there was no applied in some centers ultra protective lung strategy. So we don't get some data that this data could explain the mortality, like the driving pressure we see in the previous slide, 19 versus 20 pre and post ECMO. So we concluded ECMO may provide favorable outcome in highly selected patients as resources allowed during the pandemic, in situation demanding the provision of new ECMO beds in geographical challenging area and where trained specialists are available. Newly formed ECMO center with appropriate supervision of regional expert may have satisfactory results. Then I would like to thank all the team of the MOH and the ECLS chapter, including Dr. Azam for his support, Alia, and I would like to thank Hani Mufti, very, very helpful, and he did a great work in this paper. Also, I would like to thank my previous team from Prince Mohammed bin Abdulaziz Hospital, and thank you very much.
Thank you very much. This is a great presentation, very inspirational project. We're really proud of what's being done in the ECMO and also on the research project that led to a high impact publication. So we're very, very proud and happy about this. I'll open it for question from the audience. So I think maybe I'll ask, how do you see this going to impact guidelines? How do you like this to affect the guidelines? You mentioned that the ELSO guidelines recommended initially not to include the new sites during pandemic. Do you think
exactly.
How is that going to affect the finding today will affect?
It's already affected, Prof. Yassin. The updated guideline. First, the guideline was strictly recommend against new center during the pandemic. However, with this result, we succeeded to convince the ELSO steering committee. The updated guidelines in 2021 was recently published. They became more or less stringent for this recommendation, and they provide new ECMO support in selected cases where we present this data.
Excellent. One of the questions that comes always during discussion about when we select patient for ECMO is that looks like the literature about ECMO and COVID suggests that their outcomes probably not as good as the non-COVID patients. How do you comment on this?
Right now, the only one who succeeded to compare ECMO in COVID and non-COVID was Schmidt in his paper published in Lancet. As I told earlier, Liberté experience. It was mortality less than 30%, and this was comparable to GUARD trial and Eolia trial done before in non-COVID patient. Right now, we didn't compare most of this literature. We didn't compare the result with the other non-COVID.
Okay, very good. Any questions from the audience? If there are questions, raise hands, please. So what's your next plan?
My next plan is we are trying to working again on our work here in Saudi Arabia to present something on the national level relating to the GREED project by Dr. Azzam in the MOH retrieval, and we wanted to evaluate our results. This is the main project, and the second project also we want to start prospective study to comparing between heparin and librudin in COVID ECMO patients.
Wonderful results. So with this, I'd like to thank you very much for your presentation and the great work. And I'd like to thank all the 4 speakers, really amazing progress in critical care research, very impressive, and looking forward to high impact, influential papers that will affect practice and represent the kingdom and the critical care in Saudi Arabia in the international literature. So very proud of all this work is being done. And next month, I think we're going to have residents and fellows projects, and I'd like to invite everybody to attend and provide support also to our trainees research. So thank you again. Yatikum Afia. Have a good night, everyone. Thank you.